Our next speaker is Dr. Wennergren. This is a multi-center study that he'll be presenting, or she, primary fascial closure with mesh placement during laparoscopic ventral hernia repair, a risk-adjusted comparative study.
Thank you. Good morning. Thank you, Sages, for the opportunity to speak with you and hopefully address the question of whether or not primary fascial closure should be attempted during laparoscopic ventral hernia repairs. I have no disclosures to discuss. As a way of introduction, approximately 350,000 ventral hernias are repaired annually in the United States at a cost projected to be around $3.2 billion. And laparoscopy is a commonly employed means. Primarily, the bridge repair is a primarily employed means in attempting to repair these ventral hernias. However, many of our field have suggested that we should attempt primary fascial closure during laparoscopic ventral repairs for a number of reasons, less of which to say that this is a way we try to attempt to repair these ventral hernias during open repairs. Several number of retrospective studies have been performed in the past attempting to address this question, primarily comparing primary fascial closure versus bridge repairs during laparoscopic ventral hernias, trying to demonstrate a reduction in terms of recurrence, stromal formation, or surgical site infection. Unfortunately, many of these studies were underpowered, small single institution experiences that oftentimes did not achieve statistical significance. Therefore, the purpose of our study was to confirm, namely that which previous studies have suggested, that primary fascial closure of defects during laparoscopic ventral hernia repairs does in fact result in a reduction in recurrence rate, stromal formation, and surgical site infections. Therefore, after obtaining institutional review board approval, a retrospective study from 7 separate institutions identifying all patients undergoing ventral hernia repairs over a 2-year period were accrued. Exclusion criteria included the following: those patients having undergone only open ventral hernia repairs, or those undergoing laparoscopic converted to open ventral hernia repairs. Laparoscopic hernia repairs that were attempted but with no mesh placement, those classified as CDC wound classes 2 or higher, those patients having undergone additional procedures at the time of their ventral hernia repair, for example, cholecystectomies or colostomy reversals, as well as those patients with follow-up less than 1 month. Patient demographics were collected as demonstrated here. Hernia characteristics in terms of width, length, and overall size of the defect were also analyzed. And of course, perioperative outcomes in terms of recurrence, seroma, surgical site infection, reoperation rates, and readmission rates were also evaluated. And again, the 2 groups of question, those patients undergoing laparoscopic ventral hernia repairs with primary fascial closure as opposed to those with bridged repairs. Statistics employed included chi-squared analysis, analysis of variance, Kruskal-Wallis tests were appropriate, as well as a subgroup analysis looking at hernia defect width, age, BMI, and gender, as well as a propensity score, adjusted logistic regression, controlling for age, gender, immune suppression, ASA score, BMI, smoking status, and those patients undergoing acute hernia repairs. In total, 1,594 patients were identified having undergone ventral hernia repairs at these 7 institutions over a 2-year period. 1,232 were excluded for having undergone open repairs, in addition to 34 having undergone laparoscopic converted to open repairs, 9 that did not have mesh placed during their laparoscopic repairs, 47 that were classified as CDC wound class 2 or higher, 17 having undergone additional procedures at the time of their laparoscopic ventral hernia repairs, and 59 with follow-up periods of less than 1 month. That left us in all 196 patients who had undergone laparoscopic ventral hernia repairs, with 97 undergoing primary fascial closures as opposed to 99 with bridge repairs. The mean follow-up time for this period was, for this group was 17.5 months, with a range of 1 month to 5 years. Comparing both groups with regards to patient demographics, both were fairly well matched in comparing primary fascial closure to bridge repairs, with the exception of ASA class and a history of prior surgical site infections, which was higher in the bridge repair group. Also, age, BMI, and overall hernia defect size were not different between the 2 groups. Initial analysis comparing primary fascial closure to bridge repairs did not demonstrate a statistically significant difference in terms of recurrence, surgical site infections, deep organ space infections, readmission rates, reoperation rates, or seroma formations. A subgroup analysis was also performed. Here's the example given with hernia width defect, subcategorizing patients into defect size less than 3 centimeters, those with defects 3 to 6 centimeters or greater than 6 centimeters, also evaluating for in terms of recurrence rate, surgical site infections, deeper organ space infections, readmission rates, recurrence rates, and seroma formation. And again, unfortunately, none of the variables achieved statistical significance. We also performed a subgroup analysis in terms of age, gender, and BMI none of which achieved statistical significance. A propensity score analysis was then performed, controlling for age, gender, immune status, ASA class, BMI, smoking status, and those patients undergoing acute repairs. Again, evaluating for reductions and recurrence, seroma or surgical site infections. But again, this unfortunately also did not achieve a statistically significant value. Therefore, in conclusion, our multi-centered retrospective study was unable to confirm or demonstrate a difference in terms of recurrence, seroma formation, or surgical site infections when comparing patients undergoing primary fascial closure as opposed to bridge repairs during laparoscopic ventral hernias. However, additional investigation is needed in the future, primarily focusing on patient-centered outcomes in terms of acute versus chronic pain, patients' cosmesis or overall satisfaction, and overall function. Currently, we do have ongoing randomized controlled trials in the accrual period, and many institutions and some institutions awaiting IRB approval to address these questions. Thank you very much, and I'd be happy to address any questions.
Thank you, Dr. Wennergren, for that good presentation. I have a question. I recognize that this is a retrospective look at your database, not conducted prospectively, but was there any consensus or standardization on how you measured the mesh or size of the mesh for the original defect or closure or limitations?
So standard practice is 5 centimeter overlap for the defect size. Okay. So whether or not those are either a primary fascial closure defect or a bridged repair, we always attempted to achieve a 5 centimeter overlap.
So 5 centimeters of the original?
No, so if of the post-closure. So if it was a primary fascial defect, a minimum of 5 centimeters was achieved.
So you put a 10 centimeter wide piece of mesh in all of your primary fascial closures, basically?
Right, a minimum, yes.
Hi, Matt Goldblatt from Milwaukee. Nice job.
Thanks.
Maybe I missed it, and I apologize if I did. What was the average length of time for the follow-up? And because you made a claim about recurrence, which is obviously one of the big things we always look at when dealing with studies. Was it?
Yes, so the average mean follow-up was 17.5 months. The range was 1 month to as high as 5 years. 17.5 months was the mean, though. Yes, sir.
Ben Paulos, Nashville. Congratulations on a well-done study. I just had 2 questions for you. The first is, as far as recurrence is concerned, how is that assessed? And then the second question is, what size of defect do you feel uncomfortable closing? What's that threshold? Because certainly a 2-3 centimeter defect is easier to close than a 6-7 centimeter defect.
Right.
And when do you worry about the tension placed on that, knowing that that may fall apart in just a couple of weeks? Thank you.
Right, so with regards to the second question, there's no good answer as to what cutoff do you decide to abandon attempting primary fascial closure. In the literature, there's been, and at least the reviews that we were able to study for our purposes, the defect size, or at least a width of 12 centimeters, was the maximum width attempted and was successfully closed. Really, in terms of attempting to do a primary fascial closure, as long as you can get it together without extreme amount of tension, we would attempt to do these closures. Again, this was completely surgeon preference at the time of surgery. There was no standardization. Again, this is a retrospective study, so obviously going forward, we're going to try to evaluate that further. And I apologize, what was the first question?
How did you assess recurrence?
Recurrences were assessed primarily clinically. If there was any question, CT scans were obtained. Yes, sir.
It's Paul Daly, Vancouver, Washington. So the hernia sac, the peritoneal sac, did you remove those in any of these cases?
I'm sorry, I didn't hear it.
The
You said hernia
Hernia
sac.
sac. What'd you do with the hernia sac?
We reduced it.
So you pulled it down?
We pulled it out of the defect and reduced it completely.
So you put your mesh underneath the peritoneum? Or?
It basically places an underlay.
So my question is, then, did you excise the peritoneal sac before you pulled the fascia together?
At times, if possible, yes.
So do you think that would have effect on seroma formation?
Certainly, exactly. And unfortunately, our study did not look specifically into operative details as to whether or not the hernia sacs were removed completely. We don't have those details. But certainly, I think that certainly could contribute to certain stromal formations.
Thanks.
Thank you.
John Lynn, Chicago. I really enjoyed your presentation. Were you able to tell from operative reports, was there a different, and I may have missed this, was there a different way in which people did the primary fascial closure? Did they do intracorporeal suturing, transfascial suture passing?
Yeah, primarily they were transcutaneous. Again, I think going forward we should look at not only transcutaneous but also intracorporeal closures of these primary defects because of the risk potentially of granuloma formation, which in theory on one end could increase your surgical site infection rate. But primarily they were all transcutaneous closures.
I just have one more question to ask you
Yes,
too. So if I read that slide right, you said you had a 20% recurrence rate, basically in both groups. So have you guys looked at the 20% recurrences in your primary fascial closure? What was the mechanism of failure? Was it just above the mesh? Was the mesh pulling away? Did the fascia open back up? I think that's a pretty rich group of patients to figure out. Some of the statements which a lot of people are asking about fixation, how much overlap do you need? So what do you think?
Yeah, and that I honestly I do not have the details of that question. That's an excellent question, just I don't have the details from that analysis.
One last question, Dr. Brenner. So you may not be able to tell this across institutions, but at Kentucky, did you notice the difference between the two groups in terms of pain? I mean, a 12-centimeter wide defect is fairly large to bring together.
I mean, these procedures by nature are, compared to laparoscopic procedures in general, are fairly painful. And we did not evaluate that in our patients. And so I'd be guessing to suggest that the patients potentially had a decrease in their pain outcomes when you try to attempt to close the defect primarily, because that's what we try to do open. I don't know. So that's what we're going to look at going forward with this randomized control trial that's currently ongoing.
So for the final question, if you had an 8-centimeter incisional hernia after a sigmoid colectomy, would you want your fascia closed primarily laparoscopically?
I would attempt to do it.
Never let the data get in the way of your personal bias. That's a good job. All right.
Thank you.
Okay, thanks.